We're covering basal cell carcinoma, malignant melanoma, squamous cell carcinoma precursors, and finally, soft tissue sarcomas. 4 fast-paced topics.
Okay, let's dive into our first section, basal cell carcinoma, or as we're calling it, the local invader.
So a major, absolutely crucial defining term you need to know right off the bat is the rodent ulcer. This is the classic name for a basal cell carcinoma, and it gets that name because of its unique, highly exam-tested behavior. It is profoundly locally invasive. It essentially burrows extensively into local tissue, completely destroying whatever's around it. But, and this is a massive differentiator to keep in mind, it doesn't show distant metastasis. You will rarely, if ever, see lymph node involvement or distant spread with a rodent ulcer. It destroys the neighborhood, but it doesn't hop on a flight to a new city.
Now, what causes it? The primary risk factors are UV rays and a white population demographic. But you definitely can't forget the familial lick, which is Gorlin syndrome. As for the types, nodular is by far the most common, but I want you to really notice the morphic type. Why? Because it specifically releases an enzyme called collagenase 4. This stuff literally dissolves through tissue, making the tumor highly infiltrative. Clinically, you're looking for a lesion with rolled out, pearly white edges. Anatomically speaking, these almost always pop up on the face, specifically above an imaginary line joining the angle of the mouth right to the ear lobule.
For those high-risk or recurrent BCCs, especially when they're sitting at really cosmetically sensitive areas on the face, we use a technique called Mohs micrographic surgery. It's a very specific real-time sequence. First, the surgeon shaves off a single layer. Next, they analyze it immediately under a microscope right there in the operating theater. And then they just repeat it, layer by layer by layer, until the margins are completely tumor-free. Yeah, it is incredibly time-consuming, but cosmetically, it's essential because it saves as much healthy tissue as physically possible.
All right, shifting gears, let's move into much more dangerous territory with Section 2, malignant melanoma, the aggressive spreader. And this brilliantly illustrates the different types and prognoses directly against one another. Superficial spreading is the most common, and it often arises in pre-existing moles. Surprisingly, it actually has a good prognosis because it stays in this horizontal growth phase for a really long time before invading deep. Then you have lentigo maligna, the in situ variety usually seen in the elderly. This one has the absolute best prognosis. On the flip side, acral melanoma is the most common type in dark-skinned populations, usually popping up on the palms and soles, and it's highly aggressive. Nodular melanoma? That one has a rapid vertical growth phase right out of the gate, giving it the worst prognosis overall. And finally, desmoplastic melanoma. This usually shows up in the head and neck. It is extremely painful due to perineural invasion, which is also exactly what causes its very high local recurrence rate. So if a patient has a bunch of moles, how do you know when one is actually turning dangerous? Well, you've absolutely got to memorize this rapid-fire ABCD checklist. A stands for asymmetry. B is for borders becoming irregular. C points to a recent color change. D means a diameter greater than 6 millimeters, and E is for evolution, meaning the mole is actively changing in size or maybe becoming itchy and oozing. Any of those are massive red flags. To actually confirm a melanoma, a biopsy is done to assess the depth of invasion. Make sure you note these specific immunohistochemical markers because they are incredibly highly tested: S100, HMB45, and melon A. Got those? Great. Then, to stage the cancer and check if there's been any lymphatic spread, doing a sentinel lymph node biopsy is the gold standard procedure. Staging the depth of melanoma relies on 2 distinct systems, and it's vital to know the difference. Clark's classification is qualitative. It maps strictly to anatomical layers, moving from stage 1 in the epidermis all the way down to stage 5 in the subcutaneous tissue. The Breslow classification, on the other hand, is purely quantitative. It's based on very precise depth measurements in millimeters, grading from less than 0.75 millimeters all the way up to greater than 4 millimeters. Now, regarding surgical excision margins for melanoma, 2 centimeters. That is a hard, data-driven limit. According to the NCCN guidelines, even for melanomas with a depth greater than 2 millimeters, taking surgical margins greater than 2 centimeters does absolutely nothing to reduce local regional recurrence rates. Taking a 3-centimeter margin offers 0 benefit over a 2-centimeter margin. So 2 centimeters is the magic number. So the crucial point we need to take away regarding prognosis is this. If the lymph nodes are negative, then the depth of invasion is your critical factor. But if those lymph nodes are positive, that involvement overrides the depth entirely. lymph node involvement absolutely dictates the patient's overall prognosis. All right, quick shift. Section 3 covers the critical precursors to squamous cell carcinoma, sebaceous horns, and Marjolins ulcers. First up is the sebaceous horn. This is basically a keratinous growth that frequently emerges as a complication of a regular sebaceous cyst. Second, and this one is heavily tested, is Marjolins ulcer. This arises specifically in long-standing burn scars or varicose ulcers, and it presents with these raised cauliflower-like edges. Now, the fascinating super high-yield fact about Marjolins ulcers is that lymphatic spread is exceedingly rare. Why is that? Well, think about it. The tumor is sitting right in the middle of dense scar tissue, which naturally has terrible blood and lymphatic supply, so there's no highway for it to spread. Because of this, surgery is the preferred management. You must explicitly avoid radiotherapy here. Let's move to our final chapter and see how this all builds together. Section 4, Soft Tissue Sarcomas, or the Compartmentalizers. Time for some rapid-fire facts. The most common soft tissue sarcoma overall, liposarcoma. The most common in the retroperitoneum, also liposarcoma. But if we're talking about pediatric patients, the most common is actually rhabdomyosarcoma, and its absolute most frequent location is the head and neck region. Lock those away. The etiology, or the root causes of sarcomas, is remarkably diverse. We're talking everything from radiation and chemical exposure all the way to systemic immunosuppression. A very highly specific risk factor you need to know is long-standing lymphedema. This can actually lead to something called Stewart-Treves syndrome, which is a type of lymphangiosarcoma. Also keep an eye out for Gardner syndrome. Patients with this genetic condition are uniquely predisposed to developing desmoid tumors, and those classically appear right on the anterior abdominal wall. To truly wrap your head around sarcomas, you've got to memorize these 3 golden rules. Rule 1, their spread heavily favors the hematogenous or blood route over the lymphatic route. So a retroperitoneal sarcoma will typically spread straight to the liver, whereas a sarcoma in a limb is going to spread to the lungs. Rule 2, they respect anatomical boundaries and compartments. They'll push up against fascia, sure, but they rarely breach it. This is great news for surgeons because it allows for compartmental excisions. Rule 3, their hallmark is an extremely high local regional recurrence rate. Clinically speaking, sarcomas are defined by recurrence, recurrence, recurrence. Okay, I know I literally just told you they prefer blood spread over lymphatic spread, but come on, it's medicine, right? There are always exceptions, and exceptions make for perfect exam questions. So you have to remember the rare sarcomas that actually do spread via the lymphatics. Just use the Marcy's mnemonic. Ready? M for malignant fibrous histiocytoma, A for angiosarcoma, R for rhabdomyosarcoma, C for clear cell sarcoma, E for epithelioid sarcoma, and S for synovial sarcoma. For these specific tumors, you absolutely must evaluate and potentially clear out those lymph nodes. Wrapping up the management protocols, tumor grade, which is basically how aggressive the cells look under a microscope, is the single most important prognostic factor for sarcomas above all else. Treatment hinges on wide local excision to get perfectly clear margins, usually paired with radiotherapy to cut down on that high local recurrence. Interestingly, for those desmoid tumors we mentioned a minute ago, with Gardner syndrome, tamoxifen plays a really unique role. It turns out these tumors can express estrogen and progesterone receptors, so giving tamoxifen can actually reduce the tumor size and help prevent it from coming back. It's a pretty cool curveball. While we have covered an immense amount of high-yield data today in a very short amount of time, from millimeter-precise tumor depths all the way to the exact fascial boundaries of sarcomas, and it really leaves us with a provocative thought. As staging criteria like Breslow's thickness constantly evolve, how will continuing to refine our microscopic measurements of tumor depth and spread fundamentally change surgical precision in the future? It's something to think about as you continue to master this material. Thank you so much for tuning into this explainer. Keep reviewing these details, stay sharp, and I'll see you next time.